Hello, this will be your discussion on the disorders of the aorta and its branches. The topic that we'll discuss is aneurysm. So when we say aneurysm, it is a localized, permanent, abnormal blood vessel dilatation caused by localized weakness and stretching in the middle layer or wall of your artery. So again, the main problem is the dilatation of your blood vessel that leads towards localized weakness and stretching in the middle layer or wall of your artery. So recall that the middle layer of your artery is referred to as your media. So intima is the inner layer, media is the middle layer, and then adventitia is the outer layer. Now, so because of the effect on the tunica media, the stretching and segmental dilatation would occur. Because of this segmental dilatation, there will be a high risk for calcium deposits and atherosclerotic plaque to form also. Then the wall would tend to become brittle. And then the risk or the high risk here in your aneurysm is the possible rupture of the aneurysm. So classifications. There are classifications according to arterial wall involved. So when we say true aneurysm, 1, 2, or 3 layers of the artery are all involved. Whereas when I say fusiform, it is a spindle-shaped expansion of the entire circumference of the involved artery. Then we have saccular. Saccular is a protrusion to one side only of the arterial wall. Dissecting, the hematoma splits the layer of your arterial wall, whereas your false aneurysm is a pulsating hematoma or clot in connective tissues that are outside your arterial wall. Okay, hence it's referred to as false aneurysm because it is outside the arterial wall. Okay, dissecting again, the splitting of the layers of your arterial wall. Then, according to location, it may be considered aortic if it occurs in the aorta between the renal and then the iliac artery. Then it is considered to be thoraco-abdominal if it involves the thoracic and then the abdominal aorta. Abdominal aorta occurs more often, okay, than thoracic aneurysm. So abdominal aorta is what we refer to as your triple A, abdominal aorta aneurysm. It's a very common condition. Then cerebral occurs in the anterior cerebral artery in the circle of Willis. So your circle of Willis is a bifurcation of several circulation points, and it is very prone for arteriovenous malformation and also your formation of aneurysm. So according to etiology, your aneurysm could be classified as congenital if it involves a primary connective disorder. It is acquired if there are other underlying conditions. Atherosclerosis could also lead to your aneurysm because of the weakening of the arterial walls. And then it could be also mycotic, which is a result of fungal or even a result of your bacterial infection. Then, main problem is abdominal aortic aneurysm. So your concern here is the dilatation, stretching, or ballooning of the aorta. So when untreated, it will enlarge, and then during the enlargement, it has the possibility of rupture and even death. That's why if we feel a pulsating mass on the abdomen of the patient, our nursing intervention dictates us not to palpate that affected site, because during palpation, we might rupture the abdominal. Causes would include atherosclerosis, the most common cause. Then you have congenital weakening of the artery or trauma, and then other diseases. Risk factors. So genetic predisposition is one. Smoking is also one. And then we also have hypertension. Clinical manifestations would include the following. So signs of impending rupture would be intense abdominal pain and back pain. The pulsating abdominal mass in the middle and upper abdomen is present. So again, pulsating abdominal mass. And then if it is a rupture of your AAA, there is a constant intense back pain. And then sudden decrease of your blood pressure, sudden decrease of your CBC component, such as your hemoglobin and hematocrit, indicative of bleeding. Then a retroperitoneal rupture may result in hematoma, which is visible in the scrotum, the perineum, the flank, or even the penis. Then, what are the laboratory tests and diagnostic tests for this one? Of course, your abdominal ultrasound. Your abdominal ultrasound can be used to visualize for the presence of your aneurysm. So as you can see, this ultrasound image would show triple A. Okay, that shows the area of lumen and then the thrombus. Then other diagnostic tests would include your CT scan or MRI. Then you also have your duplex ultrasonography or CTA. And then you have your renal function studies and then chest X-ray. Okay, so this one is an indication of aneurysm already. Medical management, drug therapy will be close monitoring. I mean, part of the management is to closely monitor the size of the aneurysm. However, for the drugs, you need to give antihypertensive agents because if there is a sudden increase of the blood pressure, it may result to rupture. Okay, and then uncontrolled hypertension also increases the size of your aneurysm, increasing the risk also for rupture. Management for your aneurysm may be open repair surgery. Okay, that would be the standard treatment for aneurysm shown on the left slide. And then you have your endovascular management. Your endovascular repair or management is the mainstay of therapy for treating intra or infrarenal abdominal aortic aneurysm. So as you can see in your endovascular repair of an abdominal aortic aneurysm, what happens is that the stent graft is inserted through either the right or left femoral artery. And then this graft will be guided towards the aneurysm site. Whereas in an open repair, of course, the site of aneurysm is open. Okay, for this one, for your endovascular repair, it says endovascular, so it just passes through your major blood vessel. Nursing management. So you need to watch out for the signs and symptoms of possible rupture, which is indicated by intense abdominal pain and back pain, which could be intermittent or persistent. Then you need to watch out for vital signs, watch out for hemorrhagic shock because your patient would be severely bleeding. And then post-endovascular repair, the patient should be in supine position for 6 hours. The head of the bed is elevated at 45 degrees after 2 hours. The patient is advised to be on complete bed rest with bedpan to avoid increasing the oxygen demand. The vital signs should be monitored every 15 minutes. Doppler assessment is also done until the patient is stable. You need to continuously assess for bleeding, pulsation, swelling, pain, and hematoma formation. Also, you need to watch out for signs of embolization and report immediately. That would include possibly your um, extremely tender, irregularly shaped cyanotic areas, as well as changes in your vital signs, pulse quality, bleeding, swelling, pain, hematoma. Whereas you can have also post-implantation syndrome. So post-implantation syndrome occurs within 24 hours of stent graft placement because remember your graft may be perceived by the body as a foreign substance. Hence, there you have your post-implantation syndrome. So signs and symptoms of this are occurring fever, then you have leukocytosis, which is the increase of your WBC, and then occasionally you can have thrombocytopenia and increased risk for hemorrhage. Possible complications after surgery, it could be occlusion because of thrombus formation, hemorrhage because of the failure of surgery, infection due to proper or improper wound care, Then you have ischemic bowel due to poor blood supply towards the gastrointestinal tract, then kidney injury, and then possibly impotence due to the prolonged period of unoxygenation towards the male reproductive tract. Then common nursing diagnosis that your patient may have is altered peripheral tissue perfusion, then pain, risk for impaired skin integrity, high risk for infection, knowledge deficit, and then disturbed body image. Thank you very much for your attention. I hope that you are correlating this lecture towards your handouts and then your textbooks. God bless you all.